Liver pathology. Oh, people get so turned off liver pathology. It's full of complicated enzymes. But with a few simple rules, you can become a pathology superhero, even with liver pathology. In this video, we're going to talk about viral hepatitis, cirrhosis, alcoholic liver disease, and tumours that occur in the liver. Viruses can infect the liver and cause an acute hepatitis. Some of them hang around too long and cause a chronic hepatitis. Let's think about acute hepatitis first. The diagram on the right here indicates the changes that happen in the liver in acute hepatitis. Whenever I think about any hepatitis, I think about the changes that are happening in the portal tract and then in the liver parenchyma. So let's think about the changes first happening in the portal tract in acute hepatitis. In acute hepatitis, there is an inflammatory infiltrate in the portal tract. But the edges of the portal tract remain smooth and intact. The portal tract inflammation is confined to the portal tract. A lot of action is happening in the parenchyma in acute hepatitis. There's an inflammatory infiltrate. The cells become sick and balloon up. Some cells die. In particular, they undergo apoptosis. So in the liver, inflammatory cells will surround a liver cell, send cytokines that tell it to die. And that's what apoptosis is. In addition, all this swelling and dying in inflammatory cells can cause bile stasis, either in the little canaliculi that run between the cords of liver cells, or actually within the cells themselves. So, acute viral hepatitis is often associated with jaundice due to cholestasis. In chronic hepatitis, there's still an inflammatory infiltrate in the portal tract, but it's been there a long time and it's been damaging the cells around the portal tract. This has caused the portal tract to expand, and in particular, the expansion has led to fibrous bridges between the portal tract and the central vein, or between two portal tracts. Sometimes the little cells can be seen nibbling away at the edge of the areas of fibrosis, and this is called interface hepatitis. In chronic hepatitis, there's also some inflammation in the parenchyma, but often much less prominent. Yes, there's still lymphocytes and still apoptosis, but usually the cholestasis is much reduced. Sometimes the viruses can cause other changes in chronic hepatitis. So, for example, if there is a chronic hepatitis B infection, you might get to see the actual viral particles as ground glass change in the hepatocytes. In hepatitis C, the viral infection causes fat to accumulate in cells. These pictures illustrate the changes in chronic hepatitis B infection. These are the ground glass hepatocytes. What they are is viral protein products that have accumulated in the cytoplasm of cells, filling it up and causing it to have this pink ground glass appearance. We can use immunohistochemistry, in other words, antibodies labelled against hepatitis B S antigen, to show that what's actually accumulating in the cytoplasm is the surface antigen of the hepatitis B. In this slide of chronic hepatitis B infection, we can see in more detail piecemeal necrosis, also known as interface hepatitis. The little dark cells, well, they're lymphocytes, and the larger paler cells, well, they're liver cells. We can see that the lymphocytes are spreading into the groups of liver cells, eating away at the edges of those groups. This is piecemeal necrosis. Those liver cells will die, and as they die, they're replaced by fibrosis. Thus, we get expansion of the portal tract and bridges between the portal tract and the central vein. This is step one in the road to cirrhosis. So, cirrhosis is the final common pathway for many chronic injuries to the liver. What happens is, due to chronic inflammation, we have many of the little fibrous bands forming, which ends up with diffuse hepatic fibrosis. The surviving nuggets of hepatocytes then expand to form nodules. We all know that cirrhosis has secondary effects, particularly portal hypertension. And portal hypertension arises because all this regeneration and fibrosis disrupts the normal vascular arrangements, meaning that blood can no longer flow easily through the liver. You've probably heard about micronodular and macronodular cirrhosis. Cirrhosis always begins as micronodular cirrhosis. We get little bits of regeneration, but as the chronic inflammation continues, many of these die off, and just a few are left to become gradually bigger and bigger. So micronodular cirrhosis progresses to macronodular cirrhosis. One of the hidden causes of cirrhosis is fatty liver, also called non-alcoholic fatty liver disease, if there's no inflammation present, and non-alcoholic steatohepatitis, if there is inflammation present. Now, those are really long words, so we usually call them NAFLD and NASH. In the pictures to the right here, we have a fatty liver. We know it's fatty because we can see all the fat droplets as clear spaces. Now, in the stain that's on the left, the fibrous tissue has been stained blue. We can see an increase in fibrous tissue around the central hepatic vein, but also spreading between the liver cells. And this is the insidious fibrosis that happens with NAFLD and NASH. Eventually, this fibrosis progresses and all joins up to form cirrhosis. Drinking alcohol can cause several changes to the liver. Firstly, it can cause fatty liver. Secondly, it can cause alcoholic hepatitis. And both of these can lead to cirrhosis. Now, in alcoholic liver disease, the liver can go backwards and forwards between having fat and not having fat, depending on how much alcohol's been drunk recently. Fibrosis isn't reversible in the main part. So if there is inflammation and fibrosis formed, then it can progress more easily to cirrhosis. But I think the most important thing to remember is that we still can get cirrhosis even if there's just steatosis. This is what happens in alcoholic hepatitis. We have the fatty change. You can see the clear spaces, but in addition, we've got lots of little blue cells, and they're the lymphocytes. So the hepatic parenchyma is being infiltrated by lymphocytes, and they are surrounding the hepatocytes and causing them to die. The alcohol also has another, more direct effect on the liver cells. Let's think about this for a moment. What's holding these cells up? Cytoskeletal proteins. They're like the cell skeleton. Alcohol messes with these. It causes them to be clumped together, forming pink fluffy stuff, which we call Mallory's hyaline. Now, this Mallory's hyaline is really quite specific to alcoholic hepatitis, so it helps us diagnose the etiology of the steatohepatitis that we can see down the microscope. Let's change tack now and think about liver tumours. Well, the most common liver tumour is metastatic colon cancer, which we can see here in the picture on the right. Multiple cannonballs, small, round, all through the liver, is characteristic of metastases to the liver. What else can happen in the liver before we get on to the real liver tumours? Well, hemangiomas can happen in the liver and angiomas can happen in the liver. But the disease that we're all really worried about is primary liver cancer, hepatocellular carcinoma. We don't see much hepatocellular carcinoma in New Zealand, but it is the third most common cancer on a worldwide basis, and that's because of hepatitis B. So, chronic hepatitis B and C infections are present in Africa, in Southeast Asia, Japan and China, and these viruses lead to the formation of hepatocellular carcinoma. We have had a rise recently in Western countries due to the more frequent hepatitis C virus infection that we're seeing. Hepatocellular carcinoma has two predisposing factors. As I've mentioned, there are the hepatic viruses, but also cirrhosis independently increases the risk of hepatocellular carcinoma. Viruses will cause hepatocellular carcinoma in both cirrhotic and non-cirrhotic livers. So about 27% of hepatocellular carcinoma in countries that have a high risk of acquiring these viruses as children are due to hepatitis B, and most of the rest is due to hepatitis C. Cirrhosis is an independent risk factor. So in countries that have a low risk of viral infection, most of the hepatocellular carcinomas arise in cirrhotic livers. Someone who has a cirrhotic liver has a yearly risk of 3% of developing a hepatocellular carcinoma within it. So in this video about livers, we've learned about the two kinds of viral hepatitis, acute and chronic. We've thought about all the different routes to cirrhosis, including NASH and NAFLD. We've learned about alcoholic liver disease and how it can lead to cirrhosis by two pathways. And we've thought about tumours, metastatic tumours and primary tumours, which are also linked to hepatitis viruses and cirrhosis. By remembering these things, you can screen your patients who have liver disease, and you can be a pathology superhero.